The Centre presents a new podcast, CBmE U, a podcast devoted to promoting awareness and debate around controversial ethical issues in biomedicine.
Welcome back to CBmE U, a podcast about biomedical ethics. Today, are clinical trials really all that? When does a pill work better than a Tic Tac? And how do we know that ChatGBT is truly the therapist it makes itself out to be? Today, we have Professor Charlotte Blease from Uppsala University and Harvard University, and we'll be talking with us today about the placebo effect and digital health tools. Welcome, Charlotte.
Thank you. Great to be here.
Welcome. Our very first question for you today is, do you prefer coffee or copy?
I like coffee. Anything that just gives me the caffeine hit, I'm good with, but this is excellent.
It's a big hit.
It is a big
It's excellent,
hit.
yeah.
I think it's like at least 2 times more caffeine than a normal cup. So.
That's good by me, yeah.
I feel like you should warn people before you hand them that coffee cup.
Yeah, you are going to be particularly buzzed after this.
The whole day.
Augment those placebo effects, yeah.
Nicely done.
Yeah.
But then you need a control trial where you're like, oh yeah, this does nothing, but it's just nice.
Yeah, it's good.
And see if it works the same way.
Second question, where do you want to travel to next?
Oh, that's a good one. I would love to stay in Asia and do a bit more travelling.
Mm-hmm.
I remember being in Thailand. It was 25 years ago. I was in Singapore. We went to Thailand afterwards, and I've really got a hankering after seeing Thailand again. So we'll say Thailand.
A hankering.
Yeah.
A hankering for Thailand.
Hankering. Well, what are you hankering for the most?
It was just such a friendly place, and there were bits of it we had. Northern Thailand we didn't visit. It was me and my sister who did the backpacking thing. There was something about the friendliness and the light and the sounds of the place and the colour. It was just so colourful. I stayed in Bangkok. I really enjoyed it. So
I also love Bangkok.
Yeah.
I remember it was one of those places where as soon as I hopped out of the airport and then got in the taxi and I looked out the window, just like this, I was like, oh, this place is awesome.
Yeah.
And I don't know why, I don't know what it is, but Bangkok is definitely one of my favourite cities.
It's fantastic, yeah.
Our final question of the podcast, and then
And
we're
most
done.
important,
We'll be wrapping up after this.
Signature question.
What song is your favourite to sing at karaoke?
I can't honestly tell you because I would have to be very drunk to sing karaoke, so I have no recollection of what I sing. Probably Frank Sinatra or something ridiculous.
Fly Me to the Moon?
I Did It My Way.
No, That's Life. Do you know that one?
Yeah.
I think I sang that once very badly in a karaoke bar in Paris.
I don't know if it'll offend you to know that the first version that I attached to of that song is the Westlife version.
Oh, is it? Shame on you.
That's why I said it might offend you. Hey, I was like 7.
So you don't do karaoke very often?
No, I don't.
Okay.
Yeah.
All right.
For the benefit of society.
Yeah, but I think you gave a very polite answer to that question.
Yeah.
We've had guests come on and say, yeah, I think I'd rather die.
Yeah. I wouldn't go that far, but it is excruciating. Yeah.
I think Julian did say something along the lines of, over my dead body, would I do that again?
Yeah.
But he did say again.
He did
I
say
still
again.
remember that. I still remember that. I mean, it means Julian's done it at least once.
I still think it's possible. Okay, so we're going to start off with a kind of basic question.
Yeah.
What are placebos and what are nocebos, which I know you've talked about as well before? And how can AI systems bring them about? What do they have to do with placebos and nocebos?
So first of all, I would differentiate between placebos and placebo effects. So I would say a placebo can mean a couple of different things. It can mean in a sort of common vernacular that doctors and patients might talk about, where it means giving somebody something, but you know that it's not going to be effective. And it might be to please patients or save face or a whole variety of reasons. But a placebo in a clinical trial means something very distinctive, which is it's a measuring tool for measuring a treatment that's under investigation to see if it's genuinely effective. And then from that, I would say a placebo effect is something very different again. And it could be elicited by placebos understood in either of those senses, or indeed by any treatment or no treatment at all. And it's the effect that arises when an individual expects a treatment, or it could be behaviours from somebody who's helping them that elicit genuinely beneficial effects. And this has been known to be useful in reducing pain, anxiety, depression. And then the flip side of that, if you like, is often characterised as the evil twin, is the nocebo effect, whereby if you expect a treatment to be harmful to you in some way, then it does actually result in some kinds of nasty side effects or anxieties and so on. Nocebo effects are much less investigated than placebo effects, but both of them are really relevant in healthcare contexts. And I also want to say the evidence doesn't suggest any of these effects are cure-alls, or they're not useful for lots of conditions, but they can be meaningful effects for lots of conditions and symptoms.
So my understanding of a nocebo effect actually comes from an episode of House MD, where most of my medical knowledge comes from. I remember there was an episode where House and the big boss lady who heads up the hospital are on a plane, and then everyone's getting hysteria about this bacterial rash spreading throughout the plane, and everyone starts throwing up, and then he runs a quick placebo or test on them, and it turns out that they're all just a bit hysterical. Is that the same thing?
So the nocebo effect, identifying when something has led to these sort of negative expectancies is quite difficult to do, but certainly, as you say, at a public health level, it could be relevant. And take one example, COVID and the vaccines. So in clinical trials, when people were given the vaccine versus a control saline injection, but also told about the potential for side effects, people in the control conditions did experience side effects. So that's a big area for nocebo effects, disclosing the potential side effects of treatment, and this is what creates this ethical dilemma, whereby we want our clinicians to be open and honest, but we also don't want them to, first do no harm. We don't want them to disclose things that then are sort of self-fulfilling and lead us to actually feel harm. I'll give you an example of when I got my COVID vaccine. The nurse was very nice, and she said, you're going to feel a little prick and you're a little, a bit sore in your arm. But she said, it'll be okay. But 12 hours, was really specific. She said, 12 hours from now, you might get a headache and you might feel a bit shivery. And I thought, did you really need to be so specific? But I looked at my watch, and then 12 hours later, I actually did start to feel a bit. And I wondered even though I was aware of this phenomenon, I wondered, was part of it attributable to just these negative expectancies? But yeah, so it's enough to create a dilemma in medical context. What should clinicians do or say?
Mm. So how does AI come into that space?
Yeah, so it's interesting. We've got these chatbots now, your ChatGPTs are conversational. They have the back and forth. And because people tend to anthropomorphize these tools, they may consider them to be authoritative and confident. But also we've got a whole range of studies now which suggest that they could be as empathetic, or indeed even more empathetic than clinicians. Now, what we know from placebo effect, studies into placebo effect, is that the confidence of a clinician plus empathy can augment placebo effects. So we have this really interesting scenario now with chatbots, and I should say I don't know of any studies that have demonstrated that these tools yet. Obviously, I think that's the next step, but these could be for eliciting placebo and potentially nocebo effects too. I think it's more likely that it depends on the scenario. It depends what you're conversing with the tools about. But because they are so relentlessly polite, they respond rapidly, and they can be really impressively compassionate, in inverted commas. We would expect, I think, that these could be very important fora for eliciting these effects, given that people can use them round the clock as well, and that they have those sort of obsequious biases that are built into them. In other words, they're always trying to flatter, people please, and so on, and that might also help to strengthen a relational dimension between the individual and well, the chatbot isn't, it doesn't feel anything, but yeah, so it could be a place whereby we would expect these effects to arise.
So this is something a bit different and potentially a bit scarier than the phenomena that most of us go on the internet, go onto WebMD, put in our symptoms, and then think we're all dying. So this is worse.
I actually think the jury is out on that so far. So we've seen a lot of headlines about the potential for harm with these tools, and I believe that there are harms associated with these tools, particularly for young people, or potentially if they displace relationships. People are using them when they're lonely. These tools could then exacerbate feelings of loneliness or depression and so on. There's some evidence of that so far, but it's not causal evidence, it's correlational. But I think that one of the issues with these tools is they could be better than nothing. So if you don't have access to any kind of emotional support or advice, they may be offering you something. I'll give one example. There was a survey by Mental Health, I think it was Mental Health UK. It was a mental health foundation in the UK that did a survey that was published in November last year. And it was a representative survey across Britain. 37% of British adults said that they had used these tools for emotional support, mental health support. And that got, it was sort of staggering in a way. When you consider the lack of resources that are put into mental health care and the waiting lists, it's perhaps not surprising. But what was also hidden within this study was 2/3 said that they derive benefits from these tools. And that wasn't as widely reported. And I think we shouldn't gaslight the public either. If they're deriving some support in some circumstances, that could be a good thing. On the other hand, it's highly likely that these tools can be harmful as well. So it's going to be a mixed bag. They're going to be good and they're going to be bad. It's teasing out the circumstances for both.
And it's a situation where the numbers are probably increasing quite rapidly.
Yes, absolutely.
At 37%, probably outdated by now.
I would say so. And getting into that, we did surveys. We've been doing surveys every January for the last 3 years of doctors' use of these tools, GPs in the UK. And 2024, January, we did it. It was the largest survey at the time undertaken among doctors. And 20% said they were using these tools. It was mostly ChatGPT for any clinical task. We did it the following year. In 2025, that went up to 25%. Started this year, it's not yet published, it was 52%. So I think you were seeing rapid uptake. I don't know if we're yet at a tipping point, but people are incorporating these tools into their life. And we have fewer surveys of patients' adoption of these tools. Most of the survey research has been conducted among clinicians in the healthcare space, but it would be very surprising if patients weren't using these tools. With this first opinion service, second opinion services, for emotional support, all kinds of uses.
Yeah, I had a situation recently where a family member had a medical emergency. They're okay now, in case anybody's wondering. But, while they're waiting in the emergency room and I'm just sitting there twiddling my thumbs, I'm not just going to sit there like a schmuck. Yeah, I pull out my phone, go to, I think it was MedGPT or something, or ChatDXT. I can't remember the name. But, it was really cool. You key in all the symptoms, and I tried sounding as doctor-y as I could. And it just like, here's what the most likely diagnosis is.
Was it right?
It ended up being right.
Really?
Well, it gives answers in probabilities, right? It says this is the most likely thing, this is the second most likely thing, and all that. But the most likely answer was did turn out to be the actual answer.
Okay.
Yeah.
Okay, so quite beneficial.
Yeah, and just following up on that, in the surveys that we've conducted, we asked doctors, this was again UK GPs, what they were using the tools for. The highest percentage of it was a whole range of clinical tasks that we asked them to select, but documentation was the biggest one. So about a third said they used it for documentation. And given that in England, NHS England, primary care doctors have to share their records now, so they may be, and again this brings in the nocebo effects and placebo effects, how you write the notes, and if you're using these tools to help you write the notes, that might influence those effects. But also as to what you say about diagnosis or differential diagnoses, that was sort of the next big use. So I think it was around 27%, so just over a quarter. It was pretty consistent across all 3 years. And there was another study by the Nuffield Trust which found a similar thing. So about a quarter of GPs using it, which then starts to invite the question, well, if they're using it and I'm using it, is it a case of that the doctor has more expertise to use it effectively? And I mean, that's an open question as well. So yeah, I suspect people do use it for exactly that. I've used it for that purpose as well. Yeah.
It's an emotional use because it's like, I just want to find out what's happening.
Yeah.
Rather than just sitting there and doing nothing.
Yes. Yeah. Exactly.
Does it help anybody? Absolutely not. In terms of like can I help somebody knowing a diagnosis? No.
Yeah.
Yeah.
But they can be useful for helping you to sort through and work things out. Yeah. And of course, the issue will be with increasing online record access. In lots of countries, patients have access to their test results, lab results, medical records online, including in Scandinavia, where I work, that they will probably be putting these into chatbots, which is a huge gift to big tech as well. But using it to get more accurate probabilities. Combine that with what you're feeling right now, and you might get quite decent, more accurate outcomes than just sort of asking it directly, like you would talking to Google, so to speak.
It does sound like there's a little bit of a difference here between how you describe placebos and nocebos in the traditional sense, because you described it as a measure, something that we use scientifically if we want to do some kind of experiment. But in this case, it does sound like a bit of a side effect from how naturally polite things like ChatGPT are. And it's almost like, oh, that was a nice interaction. I feel a little bit better about myself now. So how does this difference translate into how we might treat these things differently?
Do you mean treating placebos or...
Yeah, or thinking about the issue of a placebo in the medical context versus thinking about placebo in this context. So
I think we do. I mean, a large part of my work has been saying we've got to treat these quite distinctively. And that's been an issue in a field of research called placebo studies, which is quite a broad church. It's a very interdisciplinary field, if you can call it as such, where there has been some sort of talking at cross purposes sometimes. So, and this is where it's as if you've got a bit of philosophical training and you don't mind rolling up your sleeves and sort of almost acting like a sort of sub-editor. Well, you've missed this bit. No, you're not using this term consistently. Some of it has been
That's what we're here for.
That's what we're here for, to tighten things up and nitpick.
Yeah.
And, when you, particularly in an emerging field, which placebo studies, it's quite a young field of research, studies into the placebo effect and nocebo effect. You can do quite good work. So I certainly saw a role for myself alongside other philosophers like Jeremy Howick, he was at Oxford for a long period of time. But basically so it's differentiating what we mean. And one of the things I have, get into the nitty gritty of it is also a distinction between placebo responses and placebo effects as well. And there's been a lot of conflation between those in research as well. And that again sounds sort of like narcissism of small differences, but it actually makes a big difference to measuring, to saying what we really mean by these effects and what their potential consequences can be for patient care.
So what is the difference between a placebo effect and a placebo response? And please tell me how narcissism plays a role in that. That sounds quite interesting.
No, so basically, well, I mean by narcissism's small difference is just that it just seems like a silly, trivial difference, but it isn't really. So if you take a clinical trial, a placebo randomized controlled trial, basically what happens when you allocate people to the treatment that's under scrutiny or indeed the placebo, people will respond when they're under investigation. So there's a lot of noise basically in clinical trials. Natural history, some people are going to feel better anyway. There's such a thing as the Hawthorne effect. So if you know you're being studied, you might behave a bit differently. Responder biases. If somebody comes around in a white coat and a clipboard, you might respond in a more people-pleasing way. And then there's also genuine placebo effects whereby you start to feel a bit differently because you expect to feel better. Or nocebo effects, you think, oh my God, this thing has side effects or whatever it may be, and you start to feel worse. So there's a lot of noise in clinical trials that needs to be screened out. And that's really the purpose of a placebo. So you're trying to mimic everything about the treatment under scrutiny except what you think makes a difference. So that's the issue. And if we don't, so really a clinical trial, a placebo there is trying to screen out that noise so that we can make a good inference about what is happening, if anything's happening at all. So all of that noise can collectively be called placebo responses. It's sort of undifferentiated, and it's really the response that happens after you've been given a placebo. And if you've been given the treatment under investigation, you're going to get a sort of placebo response too, as sort of this undifferentiated response to the treatment as well. So that doesn't mean that it's all necessarily as a result of expectancy, it's like placebo effects. So that's where the difference is important. And I think what tends to happen is that researchers look at clinical trials and they see, gosh, there was a very large placebo response here, ergo there was a very strong placebo effect. But it's not the same thing. And this is where we have to be careful, because teasing out and actually conducting experiments where you can see that people genuinely start to feel a little bit better because of placebo effects, that's a pretty hard thing to study empirically. And if you like, clinical trials are a very good place for discovering the potential for these things, but not for differentiating it.
Because we're all nerdy academics, have you ever been in a situation where somebody wants to run a test on you and you're like, all right, I'm going to freaking ace this test?
No, I go the other way. I'm like, I'm going to fail.
This is an autism test. I'm going to ace it anyway.
Yeah, the competitive streak. So these things do affect how when you're investigated. Yeah, absolutely.
Okay. I see how it will necessarily be not easy, but easier to test for placebo effects or responses in like pharmacogenic trials. So drug trials, essentially, you can just take out the active compound and give an identical looking pill to both the placebo group or the control group and the test group. But there's more to health than drugs. There's physiotherapy. There's behavioral therapy. There are things that it will be very difficult to test for without doing the thing. Like, it'd be very difficult to test if physiotherapy works if the physiotherapist comes into the room and then doesn't do anything.
Yes.
And so I was wondering about that and whether or not that's any different to AI or digital health tools.
Yeah, it's really difficult to design placebos, and this is where I think too often clinical researchers focus on, even very broadly in the medical community, people focus on placebos as a type of thing, like a sugar pill, when it shouldn't be. If you're really concerned with using this as a measuring instrument, you really, as I say, have to copy what it is that it's got to almost, if it's in pharmacology, it should look like the pill under scrutiny. It should ideally taste like it as well. There might be some similar side effect. You've got to dispense it, administer it, deliver the tool in the same way. So the same number of interactions with clinicians, those also have to be measured and made sure, so there should be double blinding ideally here, so that psychosocial aspect doesn't interfere with the clinician's expectations, subtly augment the patient's expectations. All of those things can make a difference. So even in pharmacology, there are times, there's a huge debate about this with antidepressant research, whether the controls in antidepressant research were really any good. So Irving Kirsch was a researcher there who did a health psychologist who did a lot of work and suggested, in fact, antidepressants are not more beneficial than active placebos. Now, I mean, so that's a whole body of controversial research. But you're absolutely right. When it comes to other kinds of treatment modalities, the psychotherapy is one, physiotherapy, surgery, designing these in ways that are ideally don't allow the potency, the influence of an expectation to leak in. That's challenging to do. Nonetheless, it's important to try to do. So if you look at, for example, psychotherapy, there are certain things you can do. So what we're looking for, if you like, is some sort of structural equivalence. So if you think that particular techniques in therapy are important, you might say, well, we want patients to be allocated to two groups. They see the therapist as frequently. Aspects of the treatment are pretty similar. Again, it's really hard to blind these things. If you're a therapist, you know what you're delivering, but still, nonetheless, it's important. When you do, the more structural equivalence there is, the more that there is a level of isomorphism between the treatments, and where if you like, the engine of treatment, that thing that you think makes the difference. You can see even in psychotherapy that there are very often it's how a treatment is delivered. It is patients' expectations. It is the therapeutic alliance that may actually make more of a difference in some of these specific techniques. And that's important because we're discovering that specific techniques may not always make a key difference. So it's harder to do, but that, as I say, is not really an excuse not to try to do it, because ultimately we want to know when we're delivering treatments, and when we're to be ethical about disclosing the treatments about what actually works and giving a sort of informed consent, you want to be able to do that honestly and truthfully. So that the best way to do that is still deriving evidence using placebo-controlled trials.
So going back to the role AI plays in placebos for a sec, are you concerned about anything in particular when people talk about, this AI system is causing a placebo? Is there any particular way in which, some kind of loose language or conflation might be concerning?
I mean, I guess I would say probably would want to say it's causing. Could AI be causing placebo effects? So I'd want to add placebo effects onto the end of it. And then that becomes a really interesting empirical question. Is there something about the interaction between the patient and the AI, maybe given the same sort of inputs and inputs from the patient side? Do they actually start to feel, as you say, do you start to feel a little bit better because you think that this tool is quite authoritative and it's knowledgeable and it somehow gets me, but it also gets what's going on? And that, as some researchers have said, is a good shorthand for understanding how placebo effects can arise. That the doctor, the clinician, gets the disease, so that the competency seems to augment placebo effects, but also getting me empathy augments it. And these tools, I'd sort of say theoretically at the outset, you'd say these tools could really be influencing those effects. Patients may just, and as they use these tools more and they get more comfortable with them, potentially this could be happening, and more consistently so than in human interactions, possibly, but where it can be very difficult for doctors and other healthcare professionals to demonstrate empathy all the time. They're multitasking, sometimes they're working behind computers, And also, it's just empathy is sort of a skill that people consider a soft skill, but it's really hard to get right. And it can introduce bias and so on into care too, because doctors aren't always humans aren't empathetic to. They can be biased in how they deliver empathy, if you like, where these tools may demonstrate more consistency.
One of the things that's sort of coming to me at the moment is that if the purpose of therapy or mental health treatment is not necessarily measured by like a physiological outcome, like better heart pressure blood pressure or heart rate, it's measured by how the person feels about themselves or how they perceive the world. And so if the person just by placebo feels better, is that not the same as having an actual effect? If the goal of therapy is to just feel better?
Yeah.
Or am I oversimplifying it a
yeah,
bit?
so, yeah, exactly. So if you can ask people, how do you feel afterwards? Do you feel better or worse? But even, so I think we'd still want to say that and here's the point on the rationale behind a placebo-controlled trial is that you still want to be able to say what caused the difference. So you're right. I mean, ultimately, you might say if somebody is even given a sugar pill and they start to feel better, that's not trivial. And it might, as some researchers have said, well, in fact, when you do these experiments and you tell people, I'm giving you a placebo and it is a sugar pill, I think this will make you feel better. And in fact, they do feel better. They've argued that, there's a space for that in healthcare. But where I've pushed back against that is that, there's nothing wrong with that being the case, but actually a lot of the studies which have investigated these so-called open-label placebos, for example, haven't been terribly well designed. So the point being, it's not really clear if what we say makes it, the placebo in this case actually does make a difference to care. So this is where this research gets really thorny and intricate and it's the same in psychotherapy. You might say, look, if it makes a difference, people feel better, that's good, that's all that matters. Yes, but at the same time, what also matters is that we decide at scale whether treatments are worth rolling out. And if we don't know if that they make, and this is where the design, the methodology is really critical because it has these downstream consequences for what we recommend. The other aspect of it too is the investigation of harms into psychotherapy is not all that extensive. So there have been a few studies, and Scott Lilienfeld was a cognitive scientist who he's since passed away, but he was really one of the few pioneers who looked at the potential for harms in psychological treatments. And he estimated about 10% of treatments led to patients feeling worse. But these aren't routinely explored. And what's interesting about investigating AI as a sort of modality or as a method of delivering potentially treatments is that people tend to hold it to a higher bar. Now everybody's like, God forbid that people use these sorts of tools because they could be harmful. Whereas, which is a good thing, it's good to be cynical, but and keep an open mind about the benefits and harms. But what's interesting, I think, is when we look at psychological treatments, we haven't had that same apathy or worry. Possibly because we have an assumption that talking doesn't really lead to that. It can't possibly lead to that many, that much scope for harm. But in fact, there is some research that it does. Not everybody does well after psychotherapy. And that again is going to depend on, could be therapist factors, patient factors, and what they consider to be useful in therapy, whether they're not convinced it's useful and they think, God, all therapy sucks if this doesn't work, or there could be a lot of things going on. So I find the parity, the distinct, how we hold AI to a higher standard, I think, is interesting in itself and quite illuminating.
That's why I keep telling you, stop trying to get me to go to therapy, man.
Like a year ago, James and I had a massive debate and/or argument where I was like, no, like I do firmly believe that everyone should go to therapy at least once in their lives. Like I do think that there are things that a therapist can help you with that it's not either your friend's responsibility or that your friend has the professional capacity or bandwidth to deal with you. James is like, no.
I had an argument. I didn't just say no.
Yeah, but it is quite interesting because a lot of people drop out of therapy. So something like 20% of people drop out after the second session. Now that's the attrition rate is quite interesting too, and it would be really interesting to see if, comparatively, I mean, if people can tend to get it. Here's the issue: they may get too addicted and too dependent on chatbots as well, but people may be depending them on these tools for emotional support in ways that are similar to what you might depend on your friends for as well. I have an article under review. I don't know what I should say anyway, but basically the idea that that chatbots can be obsequious at times and they can be people pleasing. Friends can be people pleasing too. Friends don't always tell us. There's literature on this. They're not always going to tell us, their bum looks big in something, or we've got leave that partner you're with, I don't like him, or people choose the timing when they tell things, so they're not always upfront and honest. So you're right, a good therapist could tell you in a gentle way some home truths. The interesting question is, can you use these tools to prompt you to do something similar? So there's this sort of blurring, if you like, between what these tools can do, and how they can do things better.
This might be a little bit telling, and I wonder if this says more about me than about these chatbots, but I keep getting these ads on Instagram for these chatbots or like these tests that you can do to be like, am I the problem? Am I a narcissist? How toxic are you? And I'm like, Jesus Christ, like how do my cat reels and swimming memes like collaborate on identifying if I'm a narcissist? So yeah,
I'm
Instagram
sure everybody
is actively
gets those.
Pointing out some home truths.
Yeah. Oh God. Well, no comment on that.
If any of the listeners are in the same boat, I get you.
I'm sure many people get it.
Thanks, James. Thank you. I feel so supported by our friendship.
I try. You know what Charlotte was saying about how, friends are often obsequious people pleasers. You don't have that problem with me. I got you, man.
So, my next question is, if it's extremely difficult to figure out if digital health tools and like these online chatbots like ChatGBT or the more specified ones like Therabot or Rosa, for example. Rosa is a genetic counselling support tool. If we can't really test them in that same placebo control way, how can we really be sure that they're like beneficial, that they're actually doing good?
Yeah, exactly. And I think that an article I wrote with Leo Druart, French researcher, was that it was in Journal of Medical Ethics, Practical Bioethics, and we argued that, in fact, we really should be striving to do placebo-controlled research here as well. Just because it's difficult doesn't mean we shouldn't try to do it. And the issue with Therabot was very interesting because this was a tool that got a lot of traction in the media. And it was published the study was published by New England Journal of Medicine AI. It's a really prestigious journal. But the control in this case was treatment as usual or waitlist. And that's not effectively weeding out all of those things I talked about earlier. Is it the responder biases? Is it natural history? Is it Hawthorne effects, placebo effects as well? So what we don't really know is, does Therabot actually make a difference to people outside of a clinical trial? That's really critically important before you start recommending these treatments at scale to people. So there are ways in which you could try, as I said, to give something that was structurally equivalent there. You're getting patients to do, that is dispensed, that they're using the tool maybe the same number of times per week. There's maybe some sort of homework attached to it, whatever. There's something that the patient has to do where the interface is sophisticated looking so that they can't break blind. And of course, asking patients as well, do you think you've been allocated to the treatment or the control at the end of it is important as well. So I don't think we should give up on that task. It is really important in order to discern what is it about these tools that might make a difference to people's lives, or if it's not making a difference, we've got to know that.
A follow-up from that then, I know that there's a lot of ethics around withholding drugs from patients where you have good reason to believe they would be life-saving or really beneficial. It's unethical to withhold a treatment that you think will improve them just for the sake of the study, or so some people ask. But is that really the same case with digital health tools, where you're right, we may not be able to know for sure whether or not it's beneficial, but it's clearly not as harmful to withhold it, or is it?
It could be. Well, this is the issue. So some of these tools may be harmful, and this gets into the point about we need to have a much stronger evidence base for behavioural health interventions in a whole range of guises, whether it's humans who are dispensing them or chatbots or other kind of digital fora. I think we do need more research into the harms there as well, and we just don't have enough of it. That's just been a complete blind spot in behavioural health.
So there is a potential chance that using ChatGBT or Therabot is just turning everyone into narcissists because it's a massive people pleaser, and it's like, you're right, everyone else is wrong.
Could do. Everybody's walking around with big heads after they...
Is that anything new though?
Saying so much about Gen Z. Got him. Okay, so given all these problems, so we have, it sounds like we don't even know, for the most part, whether placebos work in the first place, because a lot of the research, as you said, is kind of dodgy. Not your words, mine. And then on top of that, we have to figure out whether things like ChatGPT or other kinds of AI tools are good placebos when we don't even know if the original placebos work in the first place. So what would progress in this field look like in figuring out whether AI systems work?
So it would be, were you taking an example, say, of whether ChatGPT or similar kinds of tools are beneficial to people's health in certain circumstances? Is that what you mean?
Yeah, in psychotherapy or all these other tools.
I mean, we could do comparisons with, we could do sort of what they're called horse race studies, where you could compare different versions of generative AI tools to see, do patients feel better or worse? You can, where you could control somehow what the output looks like. You could design it in such a way that they aren't people pleasing, that they don't demonstrate empathy in their outputs. I mean, it's going to take somebody pretty ingenious to be able to work out how we do these, but there are ways in which we could establish if these tools do make a difference to people. We could also investigate how long you're spending online. So it could be same tool, but if you spend too long on it, does this actually make you feel better or worse? Is it displacing some real world activities? I think there's plenty of experimental work could be done to identify if and when these tools are useful and for whom.
What if instead of framing these tools, like Therabot clearly has the word therapy in it, what if instead of considering these tools as therapists or replacement psychologists or counselors, and we also don't consider them as friends, we think of them as this new space for self-reflection, because then it would seem less like, encouraging more people to self-reflect in a greater variety of ways throughout their daily week would be probably 100% more than what some people do already. So I wonder then if withholding these tools or trying to say, well, we're not sure about the benefits and we're not sure about the harms, is there a chance though that by withholding them, we're also making people who could have been better off actually worse off?
It's possible. And I think it's going to be really hard to, in a sense, withhold them from people. People are, the sort of realpolitik of it is people are going to use these tools. And there's very little that healthcare professionals can do about that, particularly as you're saying, it would be a level of hypocrisy if they're to say that you patients can't use these tools, meanwhile they're doing the same thing. But it could be, as you say, that, if people, one of the reasons people may be using these tools is they don't have access to rapid access to healthcare for a whole variety of reasons. And there were some quite interesting studies by the Kaiser Family Foundation in the US, which found that which looked at patient demographics and trust in these tools and whether they thought that they were useful. And in fact, it found that Black Americans and Hispanics were more likely to find the tools trustworthy and useful. Now, that could be out of date by now, but compared with whites, that's interesting. But it might reflect a lack of rapid access to care. It might reflect some differences when you do get access to care. You may be more skeptical about what doctors say or more anxious. So it's going to always depend on what you've got and compared to what. And that's going to be different for all kinds of patients as well. I mean, I've got a rare illness in my family. I've got a twin sister with a rare illness. She doesn't mind me talking about it. But she, when she goes to speak to her GP, and she had a delayed diagnosis for many years. She knows sometimes when GPs are trying to save face with her, and they don't know a lot about it. And in that kind of scenario, by the way, when she speaks to her specialist, she has a lot more confidence in them. She only sees her specialist once every year. Now, if you're using these tools in the area, and this is one of the interesting issues, people with rare diseases, and we did a very small-scale survey on this, may be deriving benefits because these tools are able to keep up to date pretty rapidly. They're very rich information sources for patients. So, again, for some patients, there could be a lot of benefits here, or they may just view them as even if they don't think the tools are perfect by any stretch. And in our study, patients and family members of those with rare diseases, they weren't completely bowled over by the accuracy of these tools, but they did find them useful. And it's the difference. It just needs to be a superior or considered inferior. That's all that matters. So perfect's the enemy of the good. These tools may be offering something to people that we shouldn't be dismissive of.
Have either of you used one of these tools before? Like the digital health ones, like Therabot or ChatGBT to do some counselling?
I have used it for advice occasionally. And it can be it not extensively, but they are so polite that it does win you over. But I did recently speak to somebody who said she used it to speak to family members on her WhatsApp group. She said her siblings were, for some reason, she was her communication style wasn't being entirely responsive with her family members over some critical issue, and she used the tool. And she said she had tears in her eyes with the level of support that she sort of garnered from the use of the tool, and it actually made a difference. It was suggesting what she should do differently in quite gentle terms, and she said she did it, and she said it had really made a difference. So I think that's probably illustrative of many people's experiences. We just don't know enough about it, and by the same token, the people-pleasing thing can be an issue. These tools they lack context. So if they're giving you advice that it does not understand fully what is going on in your interpersonal life and other, it can't take on the perspectives of others. And incidentally, therapists suffer from this too, because they've only got your side of the story. This could be a problem for the advice they're dispensing, and this is where it gets tricky.
Have you used it?
I tried using it to teach once.
Oh yeah.
I didn't use it in place of me. I was like, this is a demonstration, so to explore what AI and trust means. It ended up saying weird shit very quickly, and I got weirded out. The whole class got weirded out. I think it was a mistake.
Yeah.
We tried. It was Replica.
No, I tried. I went to use it once because NUS has our like mental health app, and in there is a like AI that you can talk to. And I got to like the third question, and I was like, "Oh, this is just going to take so much time." And there was just something weird that I didn't like, and I just shut it down and haven't used it since.
Yeah.
But I think I'm going to start getting into using like Claude and Perplexity and stuff. Just that whole guidance thing, like how to communicate to others when they're not really getting it. I know that my husband, and I'm going to say this because I know that none of his family members listen to this, but he doesn't really, he struggles to know what to say to his grandmother, who's deeply conservative and says some weird stuff sometimes. And so she'll send massive messages and he's like, I just can't be bothered. So he plugs it into like ChatGBT and it generates a reply and he copies and pastes and sends it back. Well, you can do this with family members you don't want to talk to.
I don't think that's uncommon, actually. And I think that one of these, I've noticed like in academia or, with colleagues, sometimes, if you want to send an email that you think you don't want to be sitting over an hour working out exactly what, in that sort of soft diplomatic way, well, how do I write this? They can be really useful for that and for editing. And I've noticed a lot of my colleagues' emails have got extremely slick compared to possibly mine as well. But they can be very useful for getting tone right. And I also suspect that's why healthcare professionals may be using these tools as well, particularly in the era of online record access, where you can just write letters or explain things in an accessible, sensitive way. They could be very, very useful.
Although I did see on someone's email chain, after their name, their sign off, it says, I have an existential issue with AI. So if you have used it, please let me know so I can never contact you again. I would never be doing that.
That's extreme. This individual could end up isolated quite soon.
Yeah. Just going to be by themselves. Anyway, that's all we have time for today. Thank you so much for coming on the podcast.
Thank you so much.
You are welcome anytime.
Really enjoyed it. Thank you.
Thanks for listening to our new podcast. Subscribe online and tune in every first of the month. In the meantime, listen to CBmE U and be savvy.